can I use this? Let's see. Okay, so I think that this last hour is complementary to the lecture that Dr. Torres just ended. I was asked to first talk about how to work up pruritus, because one of the challenge might be that sometimes people make a diagnosis of atopic derm, but it's not truly atopic derm. And then I will give an update on what we have learned recently about this complex syndrome. So to start with, we can make some important points that not all itchy patients are necessarily allergic, and it's very important to have a correct diagnosis when we manage these cases to have increased success rate. So in order to do this, I think it's also important to consider all the different factors that contribute to the itch and how to work up these cases. So, and then the last part of the lecture, I'm going to talk about the pros and cons of the various treatment options that we currently have available to treat atopic dermatitis. So it's a general concept about pruritus and allergies. As we all know, pruritus is not a specific clinical sign. It can occur for a variety of reasons. And as Dr. Torres has highlighted, secondary infections play a significant role in that. And so for that purpose, it's very important to have clear the concept of pruritic threshold. Each one of us is capable of tolerating a certain amount of stimulation and without exhibiting clinical evidence of pruritus. But once that threshold is exceeded, we become clinical. That threshold is variable among patients and can, in the same patient, can be lowered by stress. So to describe this, think about a patient that has an infection, has a food allergy, has pollen, has insects, and let's say that the red line is the threshold. So you have all these different factors, they're additive, so that pruritus becomes cumulative. And once you exceed that threshold, you become clinical. So as a clinician, I may not have to address every single factor. All I have to do is make my patient, quote, subclinical and bring it below a clinical threshold of pruritus. So it could be as simple as getting rid of the fleas, getting rid of the infection. So you could still have a food component, you could still have a pollen component, you just are not enough to become clinically relevant. And so as clinicians, we play with identifying that threshold in each patient and figure out what does it take to make that individual patient comfortable. So the secondary infections, we talked about this many, many times, are an important cause for treatment failure. So you will go home and think about this in your head over and over. Do cytology every time you see a derm patient to make sure that you have a correct diagnosis. I'm going to skip all this part because we already talked about this a lot. All I can tell you is that Demodex can look like allergies. So don't underestimate these cases and necessarily assume that you're dealing with an allergic dog. We talked about dermatophytes, and so the workup, that is we already talked about extensively. I had some slides about food allergy. It's a very loaded topic, as if you have learned today. So some things are very complementary with what Dr. Torres had just explained, that basically, sadly, we do not have a test. So when we work up these pruritic patients and we need to figure out, what is the exact diagnosis for pruritus, we are stuck having to do this food trial for all patients in which we have ruled out the parasites and they are non-seasonal. So there are pros and cons of the various options. And I can tell you that when I started derm, it was pounded that we would take this dietary history, right? And so the dogma was that you could not be allergic to something that you had never had before. And now, obviously, we're not exactly sure about this because there are studies that, at least in vitro, have shown cross-reactivity. As Dr. Torres has highlighted, we have no idea whether this is clinically relevant. But I can tell you that there are some clinicians that now use vegetarian diets because this cross-reactivity has been demonstrated between different meat sources. And so in order to kind of like, again, this is based on serum, so we have no idea whether that plays a role. But if you really want to play safe and you want to still pick a commercial diet that is not hydrolyzed, maybe vegetarian might be the way to go because of this potential cross-reactivity. If you stick with the meat source and your patient fails to respond to this treatment, this food trial, you may not 100% rule out food allergy, which is a very difficult thing to explain to clients, right? You go through this aggravating process of doing the food trial and you still cannot rule it out, okay? So we are unsure about the clinical relevance of this, but if you have picked a novel protein that has a meat source, in theory, if you're a purist, you cannot say that you have ruled out the food allergy. So then we are stuck with the hydrolyzed diet. And as Dr. Torres has talked about partially hydrolyzed versus extensively hydrolyzed, we do know, based on study, that if you have chicken allergy and you're fed a partially hydrolyzed chicken diet, you can still flare. So when you're using it for diagnostic purposes, you don't know how many cases you're missing, right? Because you don't have a diagnosis to start with. And so we have accepted the fact that extensively hydrolyzed is the way to go. And there was actually a study that showed that they had chicken allergic dogs, and some were fed ZD, which is partially hydrolyzed, and some were fed the analergic, or Altamino as we call it in the States. And basically what they showed is that the dogs that were fed the partially hydrolyzed still flare, 4 out of 10, and the one that were fed the analergic did not. So basically, it sounds like at this point in time that extensively hydrolyzed is the way to go. And if my patient fails a partially hydrolyzed food trial, I still cannot say that I have ruled out food allergy. So I am kind of confirming all the things that you know has been discussed in the previous hour. So food allergy is extremely frustrating. And I have to agree that I don't think it's a very common disease, but I think it would be a bummer to miss it. You know, if you go through all the aggravation of doing skin tests and immunotherapy and all that later to find out the food is a trigger, okay? Now, in this ruling out all these diseases, contact is the other one that I encourage you to make sure not to miss. Okay, because in my experience, there are some dogs that have both atopic derm in the classical term and contact. And if you miss the contact component, it doesn't matter how good you are in managing atopic derm, you will still have treatment failure. And again, when I started my residency, the dogma was that you could either have atopic dermatitis or you could have contact allergy, because atopic derm was considered type 1 and contact is type 4, and they're considerably on the opposite end of the spectrum from the immunological standpoint. What I can tell you now, 30 years later, is that it's not true. You can have both. If you are unlucky enough and your skin barrier is damaged, you can have both types of sensitization. And matter of fact, short-coated dogs, we see a lot of pit bulls in Florida. I can tell you I've seen many of them. They're atopic and have contact allergy. But the contact allergy is what always pushes them over the edge. So I put together just a few pictures to kind of show you different cases that could have come across as atopic derm. But these dogs had a significant contact allergy component, and once you remove that, their atopic disease basically became almost subclinical. Okay, again, playing with that threshold of pruritus. So look at the papular eruption in these dogs, right? So you have this tiny papules like this. So in my experience, this is either house dust mite allergy or contact allergy. And the reason I'm saying this is that I had a model of atopic derm where we put house dust mite directly onto the skin, and we will get the same papular eruption, and it was an IgE-mediated disease. So you can have these papules with atopic derm, but it's typically just dust mites. The vast majority of clinical patients that present like this in real life have a different type of contact allergy, okay? And Sheila, you're not alone. I had the same issue with this. So what are the things to look at to kind of get clues about contact? So you have this little papules, but when I have to compare and contrast contact with pyoderma, the papules of contact are smaller, and they're all at the same stage of development, while the lesions in a pyoderma dog are at different stages of development, so that you have some papules, some pustules, some collarettes. So again, this is another case of contact allergy. These are all short-coated dogs, very sensitive to absorbing allergen. This is another one, okay? So these are all, could be interpreted as atopic dogs with the secondary pyoderma, but they had contact allergy. This is another one. So they have, basically, they could look like an atopic dog. Okay, so just keep an eye for these cases. I am confident that you have it, that you see it, maybe mixed with other diseases, but it is a significant driver of pruritus. Okay, and then the clue on the feet, look at this papular eruption, so that basically you have erythema, but you can also see that these dogs have this little papules here, right? So it's not all uniform. You have these little red dots, okay? So that's kind of like a clue that makes you think about the possibility that there is a contact component. Hey. Okay, so more feet to look at. So again, if I look here, I see that there is a little, the erythema is not uniform, but you have this kind of discrete lesions. Same here, right? So you have this red dots. So it's kind of not uniform as you would expect with an uncomplicated case of atopic dermatitis. And then the clue is when you see lesions also on area where the animal would be sitting, like, the ventral aspect of the tail, the perineal area, that kind of is definitely a clue that tells you that there is a contact component in this case. This is the same dog again, no hair, so very prone to absorb anything. So you have this very erythematous, highly pruritic papular dermatitis. And in this case, pretty much everywhere because there was no hair protection. So we talked about the patch test. I encourage you to look into that. Yes, it might be a bit of a challenge to keep the patches in place. Sometimes for dogs that are too active, I give some trazodone just for a couple of days so that they don't go crazy. It will not interfere with your patch test, but it will cut the edge so that they will not chew the patch test. And it's just a matter of a few days to kind of like get an answer. As you know, we can desensitize for type 1 hypersensitivity, but we cannot do that for type 4. So if you have a contact allergy, there is no vaccine that can be made. That's different from atopic derm. And this is also the very reason for which we cannot make a vaccine for flea allergy, right? Because flea allergy is a mixed pathogenesis, type 1 and type 4. And for the type 4 component, you cannot desensitize, okay? So anytime you have a contact component, you have to identify it and remove it. You have to do avoidance in order to be successful. And if you don't do that, then you're going to have treatment failure with the various treatments that we're using. So whether you do a bodysuit, or you identify the weeds and you use weed killers to kind of like eliminate exposure, up to you, but that's critical in all these cases. And as you can see, these are all short-coated dogs that are also actually very prone to atopic derm. Okay, and that leads us to atopic derm. So as food allergy, there is no diagnostic test for atopic derm, and atopic derm is not a single disease. Atopic derm is a clinical syndrome. So when I say it's an atopic dog, what I'm trying to say is that it has clinical signs consistent with atopic dermatitis. But because it's a clinical syndrome, we now understand that you can develop these clinical signs in a different patients may have different mediators that are important for them. Okay, so there are different pathways by which you can get to the same clinical signs. This is a critical concept because when we do treatment and we use broad spectrum drugs, let's say steroids, we are more likely, at least initially, to be successful because the steroids have such a broad mechanism of action that I don't specifically care to know what cytokine is important for that patient. I do a lot of things, right? But as we are now moving toward more targeted treatments that address specific cytokines, this is a reason for why some treatments may be very effective in one patient and not very effective in another. But when you look at them, they look like they have the same disease. They are, quote, atopic dogs. So it is a syndrome that can have different pathogenesis in different individuals, that is dynamic in the sense that different mediators may be important in the acute phase versus in the chronic phase, and they change in the lifetime of the individual, is multifactorial, so it can be triggered by environmental allergens, but it can also be triggered by food allergens, and in some individuals is not allergic at all. Okay, which is basically is something different for us in vet med, right? In vet med, when we say atopic derm, we assume that we're talking about an allergic skin disease due to environmental allergens. That's kind of like the default association that we make. But when physicians call atopic derm, they don't necessarily think of an allergic disease. Matter of fact, the bulk of their treatment is skin barrier. They will prescribe an emollient, a humectant. They don't send all these patients to an allergist to do immunotherapy. They basically treat the skin. And understand that there are some individuals that can have clinical signs of atopic derm in the absence of any allergy. Why am I saying this? That you may have patients that you swear they're atopic, and then let's say you send your serology out to have an answer about what IgE the patient has and get this negative result. And this still does not rule out that your diagnosis is correct. It is atopic. It just is not allergic. So that's kind of like a new concept for us to remember. But the bottom line is that it's a dynamic multifactorial syndrome that results from the interaction between genetic factors, skin barrier impairment, and environmental factors. So you got to have some genetics that kind of increase your risk. you may have or not some skin barrier defect. If you don't have it to start with, you will develop it as you have inflammation in your skin. And then you have these external triggers, which could be pollen, could be dust, could be food, that basically make you flare. So there are all these different factors that contribute to it. So the question is, why this disease is becoming so common now? What's wrong? I mean, was it always like that? Well, we know in people it was not like that, right? So when people had a different lifestyle, and they were not spending so much time inside, exposed to dust mite with, the kind of refined, westernized diet, allergies were not so common. Autoimmune diseases were not so common, but now life has changed. So it's not that the only people that are having children are the ones prone to allergies. It means that there is a genetic component, but there's also a lifestyle change. And the same is happening to our pets, because basically they share the same lifestyle. So there is a body of evidence now, and that is demonstrating that allergies in general are becoming more common in dogs, because dogs are, among other things, getting treated for parasites, have less exposure to beneficial bacteria, are fed this ultra-processed, carbohydrate-rich diets, just like us. And basically this is altering their microbiome and the ability to educate the immune system. The immune system needs some exposure to beneficial bacteria and parasites in order to develop tolerance. And when that is removed, the consequence of that is an epidemic of allergic and autoimmune diseases. So we are experiencing as people that, and our pets now are experiencing the same thing. So too much bathing with the wrong products will alter the skin barrier. Being too much in the house without having exposure to a rural environment is bad for the microbiome. Having a diet that is ultra processed, that does not have whole foods ingredients, they're basically minimally processed, that changes your gut microbiome, and it does have an effect on permeability. So all these things, we are altering the skin permeability, we are altering the gut permeability, and so we are increasing the risk for sensitization. Right? Even this epidemic in people that now everybody has gluten allergy. I mean, it wasn't like that before, right? So clearly there's something that we're doing that is increasing the risk for allergies. And there is a threshold for development of the disease. So I look at AD and the threshold of AD the same way I explained to you the threshold for pruritus. So pruritus is additive and multifactorial, right? So everything adds to it until you reach that threshold. Well, AD is the same. In other words, you could have some genetic mutation, but if your microbiome has biodiversity, and if your diet is, not ultra processed and whatever, you may still be below a threshold of clinical signs. This is, I think, why in the past we didn't see so much clinical manifestation of AD. But if you eventually start accumulating all these environmental factors with decreased bacterial exposure, increased host dust mite exposure, lifestyle changes, and on top of that you have the genetic mutation, then you exceed that threshold and then you have clinical manifestation. So from the clinical standpoint, I cannot change the genetics, but I can kind of work on the environmental factors, right? That's where you kind of look at what makes a difference for each patient. And I think that as things are progressing, we're almost doing full circle. We're going back to more natural. You know, at least in the US now there is this pressure to kind of feed dogs like more of a home cook or like a less processed diet, and to minimize this changes in the microbiome to increase biodiversity. So the clinical disease results from all these different factors. You know, your skin barrier that is altered, your environmental factors that increase your risk, and then how the immune system responds to all this. So how are all these things tied? Well, for one, the microbiome educates the immune system. So if you have biodiversity, whether it is in your gut, or in your skin, you educate your immune system to be tolerant. So to build that kind of response toward tolerance and not allergy. If your skin barrier is normal, if you see an allergen, you're not going to make IgE. You're going to make IgG. But if your skin barrier is damaged, anything that you put on it, you're going to make IgE. This is how actually we do it in the lab if we want to sensitize somebody. We just damage the skin barrier and then put an allergen on it. So this thing of IgE production and skin barriers, these are not two separate things. They're two sides of the same coin. So if I have repetitive exposure of an allergen or bacteria or yeast or whatever to a skin that is not normal, the animal or the human is going to become sensitized. This is why, for me, it was, for example, easy to sensitize my beagles to peanut, because their skin was not normal. All I had to do is put peanut topically on their skin, and then I fed them peanut, and they flared with atopic dermatitis. They didn't have GI. They flared with atopic derm. This is actually why children, typically with eczema, they start in the perioral area, because the idea is that they sensitize themselves by smearing food in the perioral area. So long story short, the skin educates the immune system. The fact that the skin is not normal promotes IgE production against anything that comes that way, whether it is dust mite, whether it is pollen, or whatever. So there are cytokines released by epithelial cells that educate the dendritic cells to make IgE, therefore increase the risk for sensitization. So of all the routes of allergen exposure, epicutaneous wins, always. So if I give the dust mite orally, okay, they flare a little bit. Respiratory, okay, a little bit. But if I put it topically, I have massive flare of atopic dermatitis. Why is this relevant? As clinician, we need to do primarily two things. One is frequent bathing with appropriate product, because you don't want to strip the lipids, right? So, but you want to remove the pollen. So even just frequent rinsing, there doesn't have to be any shampoo or anything, but you just want to remove that pollen. And then kind of get in the habit of prescribing some form of skin barrier repair. You pick the product that you like, but you know, many products are a combination of sphingolipid emulsions in different formulations, whatever works. But you need to kind of provide almost some sealant to the skin to minimize absorption, so new sensitization, as well as flare of clinical signs. Now, how does this immunologically, what kind of immune response occurs when the skin is exposed to an allergen? Well, that immune response is dynamic. We used to think IgE and IgE only, and we used to prescribe antihistamines. It doesn't work like this. So we know that antihistamines actually don't work for atopic dermatitis, okay? And the immunologic response triggered by allergen exposure is dynamic. varies over time. And when we are looking for a target, we are looking for cytokines that possibly are relevant both in the acute phase and in the chronic phase. So there are studies to show that if I do a patch test with an allergen and then I look at the cytokine expression, over time there is one cytokine that tends to be relevant, and that is IL-31, among others, okay? So IL-31 is relevant, is one of the mediators of itch, and may play a role in some patients, in both in the acute phase and in the chronic phase, okay? So you'll hear much more about the cytokines moving forward, but I think it's a good target to address allergic pruritus and also pruritus of some other diseases. It's produced by lymphocytes, and many cells have receptors for it, not just nerve fibers, but keratinocytes themselves, okay? So there is this cross-communication, and the keratinocytes become very active in responding to this. What does it mean to me clinically? Okay, what am I going to do? Well, as we have heard multiple times today, there are some guidelines on how to handle this atopic cases, and there are suggestions based on studies on what to do, whether you're dealing with an acute phase or a chronic patient. The bottom line is most of the time you need to do more than one thing. The approach needs to be multimodal. Hardly ever you're going to have one drug that is going to do it all. And then most of the time you need to do some form of skin barrier repair, some form of identification of the trigger, and control of the itch, because if they start demolishing themselves, they are going to impair their skin barrier even more. So even if they didn't have skin barrier dysfunction to start with, they're definitely going to have it. And so the way I look at it is like that I'm going to have a short-term approach where almost anything goes, because basically the house is on fire, so what are you going to do, right? You need to stop the itch right away, but then you need to also have a long-term plan, and I think that that's where I see sometimes the biggest, quote, errors. Just because something works well in the short term, it doesn't make it okay long-term. So if the season is long, and where I work, the season is long, then I need to have a long-term plan. Because if I'm dealing with a young dog with atopic disease, the concept that it's going to be on Apoquel or cyclosporin or whatever for the next 10 years is not going to work. These drugs are going to quit working for a variety of reasons. You're going to need more and more, and you're going to have more and more side effects. So I need to identify the triggers and possibly desensitize these patients. So acutely, I can do topical therapy, and then I'm going to pick the fastest drugs, other steroids, or Apoquel. Long term, I need to do something more comprehensive. I need to have a plan to kind of manage the skin, whether you want to do fatty acids topically or systemically. I have more time. I can have other drugs that take longer time, like cyclosporin takes 3 or 4 weeks, biologics like Cytopoint. And importantly, I urge you, I know this is maybe not a widespread thing yet here, but to work toward some form of allergy testing and immunotherapy, because currently the only thing that we have right now that can halt the progression of the disease is allergen-specific immunotherapy, so that you have a long-term plan to minimize the dependence of these patients on medications. So in terms, I just pulled some publications so that you have it for your notes. There are studies to show, because one thing that people say, well, steroids are faster than Apoquel. Okay, that's the dogma, at least in the US, and the answer is no. So there's studies that have shown that Apoquel is just as fast as steroids, whether you give oral prednisolone or even injectable dexamethasone. So it's just something that for some reason we're stuck on that concept. But speed-wise, we know that oral prednisolone and oral oclacitinib can provide relief within 4 hours after oral administration. This is a review that you can find in open access that has all the publications about Apoquel so that you kind of like have the information of the various uses of the past 10 years. And I think it's a good reference to have. Importantly, I think is, Apoquel is kind of like primarily a JAK1 inhibitor, but everything has to do with dose, okay? So you want to be on the happy side of that JAK1 inhibition because if you increase the dose too much, you could potentially alter other cytokine signaling. So the ideal thing is to be in the recommended label and dose so that you have more of a JAK1 inhibition, which is the one important for allergy and not other inhibition. We talked about infections as a treatment failure cause. I'm not going to spend any more time on that. How about the concerns about long-term use? There are studies to show that if your allergies are controlled, you need less antibacterial therapy. This specific study, which is intuitive, right? This study did Apoquel, but I think it's true for any well-controlled patient. So as antibiotic resistance becomes more common, I think we are forced to do the best we can to control allergies because we cannot afford to have too many bouts of pyoderma. This study in vitro showed that there was no immunosuppression in the long term. Every patient is different, so you need to monitor these cases because here and there, however, from the clinical standpoint, you're going to see these dogs that may develop masses and papillomas and things like this. So that is very important to consider. A published study did not find that dogs exposed to Apoquel had an increased risk for the development of neoplasia in terms of statistically significant difference. Again, as clinicians, we want to be mindful. Every immune system is different. There are some patients that do great and some patients that develop these nodules, these histiocytomas and papillomas, so we want to be mindful of that. And we do know, as we discussed this earlier, that atopic disease itself can increase your risk for lymphoma, even without having to deal with immunomodulating drugs. So keep that in mind as you evaluate these patients. You now will have Cytopoint, so I'm going to do a brief, I know you'll hear a ton more, but I am going to compare and contrast Apoquel with Cytopoint because Cytopoint is not an injectable Apoquel. Cytopoint is an antibody, a canonized antibody against IL-31. The beauty of this is not a drug, it's a biologic, so it doesn't have drug interaction, and at least in the US, it doesn't have any age limitation. While Apoquel, you cannot be used in patients that are less than 1 year of age, or if there is any history of, neoplasia or Demodex and things like this. So I use Cytopoint a lot, particularly in patients where I'm building the allergen-specific immunotherapy, because I don't want to use the steroids. I'm not comfortable using the Apoquel because I do not want to interfere with that immune response. I want to make them comfortable. And if there are Cytopoint responders, then I keep them on Cytopoint as I build the immunotherapy. And this is an important point. As veterinarians, traditionally, we practice reactive approach. And so do our clients, right? They wait until the dog is on fire before they seek help. I think we need to change that. We need to educate people and say, listen, atopic derm has a relapsing nature. That's how the disease works. So chances are it's going to have other flares. So we need to be proactive and control that inflammation and not wait until the next flare occurs. And although it seems like you're using more drugs, in the long run, you're actually using less drugs. And because it has a drug-sparing effect. If I have a massive flare, I have to use more drugs to kind of control the inflammation. And chances are I may have to use drugs that are more broad spectrum. But if I proactively give, for example, the cytopoint, then I may be able to minimize the bout of pyoderma and the use of broad-spectrum medications. And there are publications on this. That is incredible to believe that just blocking one cytokine can have a proactive effect in controlling the frequency and severity of flare. There are some dogs that respond very well, and it might be the answer for them. Now, how quickly would I expect for the cytopoint to work? According to some studies, can be within a few hours. My experience is typically a bit longer than this. It's typically the next day. And, next day, that's what I told my owners, wait until tomorrow, next day, and let me know whether you see an improvement or not. And how long does it last? It varies. Typically 4 to 5 weeks. Sometimes you may have 6 weeks. But on average, I would say monthly, so those 4 weeks. So, of course, this drug works on itch. So when they compare the speed of action in controlling pruritus of cytopoint compared to the cyclosporin, your cytopoint decreased the itch faster than the cyclosporin. That's to be expected, right? Because you're blocking the cytokine that is responsible for the itch. Okay, but dermatitis-wise, there is no significant difference in the efficacy of the cyclosporin versus the cytopoint. So comparing, contrasting these different treatment options. So I re-emphasize the concept that allergy testing is not a test to make a diagnosis. It's a test that we do to identify what to put in allergen-specific immunotherapy, and encourage you to do whatever is possible to provide that option to your patients. I think that even if we have a lot of new tools now that are available to make our patients comfortable, if you have a young animal where the season is going to be longer and chances are allergy only get worse with time, if you have chronic prolonged exposure, you got to have a long-term plan. And so I, at this point, think that immunotherapy is your best long-term approach to make them comfortable. I encourage you at the end of all this to always make sure that you have the correct diagnosis. Not every itchy patient is allergic. So you go in your step-by-step process, make sure you got the right disease, and then you formulate a plan that works for your patient. So what I personally do, I consider how old, how severe, what are the expectations of the owners in terms of finances, in terms of time commitment, and I make a plan for them. I learn to keep it simple. If it becomes too complicated, they're not going to do it. So I pick a couple things that I think that they can cope with. And I gauge that based on, again, finances, the age, and so on. And basically, I make sure that I have enough tools to make it comfortable and bring it below that threshold of pruritus. I encourage you, once again, to make sure that you always do your cytology and scraping. Just because you did it at the very beginning It doesn't mean that they cannot get a Demodex later. Okay, I'll give you a very quick example. Let's say you didn't do the scraping. You put this dog on Apoquel. Later on, the vet down the road see this case, does the skin scraping, and say, Demodex. The question is, did the Apoquel give the Demodex? Or this was a Demodex dog that was misdiagnosed as allergic, and now you have the diagnosis? So I think it's very important to do that. Also, it's important if somebody is on this immunomodulatory drugs, whether it's Apoquel, steroids, cyclosporin, for years, and then things change or they, quote, quit responding, start from scratch. Make sure that nothing has changed. So I encourage you to kind of like go and through your due process. Fleas are always a complicating factor. They gotta be on some form of flea control. And if they're allergic, they gotta be on a repellent. Just taking an oral pill for fleas is not gonna help the flea allergic dog. I'll give you an example. If I am allergic to mosquitoes and I take a pill to kill mosquitoes and then I go outside, I take a walk in the swamp that is full of mosquitoes and I get chewed up by mosquitoes, I'm still going to be itchy at the end of that walk. Even if every single mosquito that has taken a blood meal has dropped dead, I am still itchy. Same is true for flea allergic dogs. Flea allergic dogs need a combination of treatments and they need a repellent of your choice. Okay, so that's basically the summary of all this. And again, I say short-term approach, almost anything is okay short-term, but do not transfer a short-term approach into a long-term approach. I think that that's when things tend to go bad, in my experience. So this is what I had for you, in kind of like a summary on atopic derm and the various treatment options you're going to have available. And I'm out of time. Do you guys have any questions?